We want to go deeper into this issue tonight, so we're now joined by Victor Rodwin. He's a professor of health policy and management at the Wagner School of Public Service at New York University. Professor, thank you for joining us.
It's a pleasure.
So tell me, having seen this piece, does it make sense for a government to target for aggressive treatment the more widespread diseases, the more easily treatable diseases like this?
I think in principle it makes sense. It's not the only example in the world. Few people may realize it, but we do it in the United States for kidney disease, end-stage renal disease. That's the only disease for which we have universal coverage, irrespective of your age, right here in the United States.
By the way, nobody knows that. I didn't know that.
Well, everybody with kidney disease knows that,
yeah.
And the nephrologists are very well versed in the fact that this is how things work. They were major promoters of that program.
So a special kind of
1972.
disease that has a special kind of treatment that gets universal coverage.
That's right. So the principle of covering everybody for serious diseases is already well established. In fact, one way we could have had health insurance in this country was to extend the number of organs covered. Imagine if we covered the heart and the liver, in addition to the kidney.
But think about it, in the Chilean case, for instance, if someone has pancreatic cancer, you get put on in the slow treatment plan, not the aggressive treatment plan.
Well, I mean, that's your adjective, slow. Within Chile, there's a universal system for everybody in principle. So the issue is that everybody has basic coverage, but if you have diseases which are susceptible to treatment, unlike pancreatic cancer, and which affect large numbers of people, and for which if you have primary care and good primary care in advance, you can avert high hospitalizations, this is a very good thing. I mean, disease management companies do this in this country. We try to treat in certain programs for well-insured people chronic disease in advance, and this is what we're talking about.
But could you see a system in the United States where we adopt widespread, going through all the diseases, which one affect the most people, that's the one that gets the special attention? Could we ever get to that system?
Well, it's hard to, we have other problems we have to deal with first. The foremost being that we have a system of rationing by price. So we already ration care in the United States based on ability to pay. And that's a morally unacceptable system in my judgment. Of course, that's a matter of values. But we did try this for the very poor, eligible for Medicaid in the state of Oregon, based on cost-effectiveness criteria, and it was considered unfair, which it is when you do it only for the poor. But remember, the Chileans are doing it for everybody, poor and rich, and they're both taking advantage of it. So the idea of attacking illnesses that have high prevalence and high cost, and averting costs, even higher costs later, that we now pay for uninsured people in emergency rooms and in avoidable hospitalizations, this in principle is the way to go.
Well, Professor Rodwin, NYU, thank you very much.
Thank you very much for having me.